Hi guys, welcome to the Prepler and ETSS. Dr. Patil here, and today's topic is on pulmonary hypertension. Now, during our ward rounds, how many times we have come across the patient's echo where the pulmonary artery systolic pressure is mentioned to be elevated, and we just tend to ignore it. Happens quite often, right? Yeah. So there is lack of awareness about the pulmonary arterial hypertension among the practicing doctors, and because of that, it is kind of underdiagnosed. So mostly when patient presents with overt symptoms of pulmonary hypertension, that is where we start diagnosing. Earlier routinely done echo findings, especially the elevated systolic pressure, we often ignore, right? Okay. Now this topic is important for NEET SS also because there are a lot of right heart catheterization data based questions which are possible. Then also questions are possible about the WHO functional class. You might get clinically oriented MCQs where you have to make a decision about how do you manage the case. So for that, you need to know the WHO's functional classification of the case, as well as what are the drugs available at your disposal. Sometimes they do mention some contraindications for particular class of drugs. So how do you make a wise choice? Those kind of questions you can experience. So we'll start the discussion by first opening up with a question. This will set the tone and it will enlighten you to understand what is important when we go further. Okay, so let me read out the question for you. So in this question, we have a 35-year-old female who was evaluated for exertional syncope, exertional dyspnea and exertional syncope. So obviously at this point of time, we would think of a lot of differential diagnosis. But in this question, they have mentioned that the echo revealed right ventricular hypertrophy and elevated pulmonary artery systolic pressure. Okay. Probably in a young female presenting with syncope, one of the important differential I would think of is the aortic stenosis, most likely secondary to bicuspid aortic valve. But here echo has not shown anything like that, and it is clearly mentioned that there is right ventricular hypertrophy and elevated pulmonary artery systolic pressure. So that is a good ground for us to think that this is a case of pulmonary hypertension. What is the cause? We will evaluate in detail. Now the right heart catheterization data is given below. They are asking what is the likely diagnosis. Now what information we have from the right heart catheterization in this question? They have mentioned the mean pulmonary artery pressure. Now how do you diagnose the pulmonary hypertension? Do we use the pulmonary artery systolic pressure or systolic and diastolic pressure, or we rely on the mean pulmonary artery pressure? Okay, here they have given the mean pulmonary artery pressure, which is 34 millimeters of mercury. They have given the pulmonary vascular resistance, which is 3.6 Wood units. WU stands for Wood units. That's the unit used for expressing the pulmonary vascular resistance or vascular resistance per se. And then pulmonary artery wedge pressure is 19 millimeters of mercury. Now, based on this, we have to answer whether this patient's diagnosis is pulmonary arterial hypertension or whether this patient's diagnosis is pulmonary hypertension due to left heart disease, or whether this patient has aortic stenosis, or whether this patient has mitral stenosis. Okay, so if you are able to interpret the right heart catheterization, you will be able to answer this question. For answering this question, you definitely need to know what is the normal mean pulmonary artery pressure, what is the cutoff used for the diagnosis of pulmonary hypertension, then how does pulmonary vascular resistance influence in classification of pulmonary hypertension, and also you should know the utility of knowing the pulmonary artery wedge pressure in classification of pulmonary hypertension. So all that we are going to learn today. Okay, so let me start with some basic readings about heart pressures. This is one image that is very familiar to you if you have watched my other cardiology lessons. And in the aortic stenosis video, I have discussed in detail the chambers and the pressure changes that happen here. Now for today, let me just concentrate on the pressure changes that are happening on the right side of the heart. That is right ventricle, right atrium, and pulmonary artery. Okay, as you can see from the image, the right atrial pressure ranges between 2 to 8 millimeters of mercury, right? Because it is receiving the blood from the superior and inferior vena cava, and the flow is constant. So you have around 2 to 8 millimeters of mercury. It's not a high pressure chamber. Now the right ventricle, if you look at the pressures, you will notice that the systolic pressure might range between 15 to 30 millimeters of mercury, and the diastolic around 2 to 8 millimeters of mercury. Okay, now if this is the representation of tricuspid valve. So if the pulmonic valve is not offering any resistance. Okay, if you remember when we discussed the aortic stenosis, I told that the aortic valve completely opens, making the easy passage of blood from left ventricle to aorta. It doesn't create any gradient because it opens almost completely. Same applies to the pulmonic valve also. So this also opens completely. So it doesn't offer any resistance when the right ventricle gets into systole. So as you can notice from the image, because the valve is not offering resistance, the pulmonary artery systolic pressure is same as the right ventricular systolic pressure, right? So pulmonary artery systolic pressure is equal to right ventricular systolic pressure. And this rule applies as long as the pulmonic valve is functionally anatomically normal. If there is a pulmonic stenosis, obviously the right ventricular pressure will rise and the pulmonary artery systolic pressure may drop, just like what happens in case of aortic stenosis, right? Okay, that's the first point. So now we know the pulmonary artery pressure readings, right? During systole, it is around 15 to 30 millimeters of mercury, and during diastole, 4 to 12 millimeters of mercury. Okay, so when you know the pulmonary artery systolic pressure, you can have a rough calculation of mean pulmonary artery pressure. But the most reliable method of calculating the mean pulmonary artery pressure is by doing the right heart catheterization. The most reliable method of calculating the pulmonary artery systolic pressure as well as right ventricular systolic and diastolic pressure is by doing the right heart catheterization, right? Okay, I hope this is clear. Now, coming back to the point. If I have to define the pulmonary hypertension, we are defining it by using mean pulmonary artery pressure and not the systolic pressure. Okay, so for that matter, we need to know what is the normal range of mean pulmonary artery pressure. Now, obviously, during exertion, the pulmonary vascular resistance decreases, cardiac output increases to facilitate increased oxygenation at the level of lung. So during exertion, pulmonary artery pressure is going to vary. So we are talking about the pulmonary artery pressure at rest. So at rest, the normal mean pulmonary artery pressure is generally 14 millimeters of mercury plus or minus 3.3. This is what the community studies tell us about. 14 plus or minus 3.3. That's the range of the mean pulmonary artery pressure. Now at rest, right, pulmonary artery pressure never exceeds more than 20 millimeters of mercury. So based on that, previously the pulmonary hypertension was defined as mean pulmonary artery pressure more than or equal to 25 millimeters of mercury. That's the previous definition of the pulmonary artery pressure. So we were using the MPAP for defining it, or in other words for diagnosis, and the cutoff was 25 millimeters of mercury. Okay, but over the years, studies have shown that the mean pulmonary artery pressure in the range of 21 to 24 is also associated with increased mortality. And majority of these patients in this range, they often progress to range more than 25 over time. So keeping this data in mind, that mean pulmonary artery pressure of 21 to 24 is associated with increased mortality, and it is also associated often with progression to higher pulmonary artery pressures over time. Now the current definition of pulmonary hypertension is revised. We are not using the cutoff of 25 anymore. Instead, we know that never in a healthy adult at rest the mean pulmonary artery pressure doesn't exceed 20. So currently we are using this itself as the cutoff. So anyone who has mean pulmonary artery pressure of more than 20 millimeters of mercury can be said to have pulmonary hypertension. Clear? So pulmonary hypertension equal to mean pulmonary artery pressure more than 20 millimeters of mercury. That's the number to remember. Okay, now comes the point. You hear these two terms, pulmonary hypertension and pulmonary arterial hypertension. Are they exactly same or there is some difference? Okay, so whenever you hear the term pulmonary hypertension, it's a broader term, just like how you have Cushing syndrome. Cushing syndrome broadly applies to any condition where the cortisol level is elevated, right? Now, Cushing's disease is a condition where the cortisol is elevated secondary to an ACTH producing pituitary tumor. So Cushing's disease is a small one disease, but Cushing syndrome is a broader term under which Cushing disease also comes in. So pulmonary hypertension is that broad term, right? Any patient whose mean pulmonary artery pressure is 20 plus millimeters of mercury can be said to have pulmonary hypertension. Now, what is pulmonary arterial hypertension, right? This is what confuses us. Now, pulmonary arterial hypertension is a kind of pulmonary hypertension or type of pulmonary hypertension where the pathology lies in the pulmonary artery. See, pulmonary hypertension can also occur because of the left-sided heart disease, right? So when the pathology is in the pulmonary artery, we will call it as pulmonary arterial hypertension. it is definitely classified under pulmonary hypertension. Clear? So I hope these terminology are also clear, and what is the cutoff used for currently the diagnosis of pulmonary hypertension. Okay, now with this definition, it's time for us to progress to discuss the classification of pulmonary hypertension, and under the same heading we will discuss the causes. Okay, now whatever definition of pulmonary hypertension I gave you comes from 2019 World Symposium on Pulmonary Hypertension. Right? 2019 World Symposium on Pulmonary Hypertension. So the definition is based on that, and 2019 World Symposium on Pulmonary Hypertension is also given as a classification. Okay, but before we go to that classification, I also want to classify the pulmonary hypertension in an older way, because we hear these terms very often. What are the terms? We hear the term pre-capillary pulmonary hypertension, and we hear the term post-capillary pulmonary hypertension. Okay, so first let me define pulmonary hypertension. Right, any patient with mean pulmonary artery pressure more than 20 millimeters of mercury. Right, that is how we are defining the pulmonary hypertension. Now this is further classified into two broad categories. One is called as pre-capillary pulmonary hypertension, and the second one is post-capillary pulmonary hypertension. Okay, now what is this pre-capillary and post-capillary? What are we talking about? Okay, to make this easy and understandable, let me take you through this image. Now we all understand that there is a systemic circulation and there is a pulmonary circulation, right? Now pulmonary circulation, actually the lungs receive two sources of blood supply, right? One is coming through the pulmonary artery and the other one is the bronchial. Now pulmonary artery is a communication between the vasculature, the capillary meshwork in the lung, and the right ventricle. Right, so right ventricle receives the deoxygenated blood from the right atrium, which receives indeed blood from superior and inferior vena cava. Now this blood reaches the right ventricle, and from the right ventricle it is going to lungs. At the level of lungs, right, around all your alveoli, there is a rich capillary meshwork facilitating the gas exchange. And once the gas exchange happens, now the blood moves to the left side of the heart through pulmonary veins. Right, so this is, I have just, for the sake of simplicity, driven one vessel here, but these are basically pulmonary veins. Right? Then left atrium receives the blood, eventually the left ventricle, and finally pumped into the aorta for systemic circulation. Right? Now, if you have a problem at the level of pulmonary artery itself, right? Pulmonary artery vascular resistance is increased because of the vasculopathy, endothelial injury, and play of various mediators. If the resistance in the pulmonary artery is increased, it is having increased tone, right? That means the pressure inside the vessel increases. So that can be one problem. So the artery can be a site of problem, right? Then second thing is at the level of lungs, because of the lung parenchymal diseases or because of the disease affecting the capillary plexus around the alveoli, that can also lead to, right, if there is a sluggish flow through the capillaries because there is vasculopathy, or if there is a lung parenchymal disease which is again affecting the flow through the capillaries, then what will happen? The pressure inside the pulmonary artery starts increasing, right? So that's what we call as pulmonary hypertension again. So that can be a second site of lesion, lungs and the capillary meshwork. Now both of these can be considered as pre-capillary. Right, means the pathology is either in the pulmonary artery or the lung parenchyma or capillary meshwork, not subsequent to that. But now if the pathology is in the pulmonary veins, right, or if the pathology can also be in the left atrium, right, for example, you have mitral stenosis, so left atrial pressure increases, there is back pressure on the pulmonary veins, and because this back pressure will indirectly influence the pressure in the pulmonary capillaries and thus the pulmonary artery, that can again give rise to rise in the pulmonary artery pressure, right? So this pulmonary veins, if that becomes the site of lesion, right, that is post-capillary, because it is after the capillaries in the pulmonary system, post-capillary. Similarly, if there is a left heart disease, that's also a post-capillary. right? Sometimes the left ventricular dysfunction, for example, left ventricular hypertrophy, right? That can also indirectly lead to development of pulmonary hypertension. There's left ventricular hypertrophy, and there is improper relaxation of the left atrium. There is improper relaxation of the left ventricle, so there is more work done by the left atrium, and then again left atrial pressure increases, so pulmonary venous pressure increases. There is a back pressure and pulmonary artery pressure increases. So all of that would be considered as post capillary, right? So now there is a question. Okay, so they can ask you a question: the lung disease, whether you will categorize it as pre-capillary or post-capillary. Obviously, it's a pre-capillary, right? So pulmonary veins and left side of the heart is post-capillary. Clear? And if it is a disease primarily affecting the pulmonary artery, clearly it is a pre-capillary. Okay. On the diagnostic evaluation, how do you get to know that whether it is pre-capillary or post-capillary? There are several clues. Obviously, if there is a left heart disease, you might have the evidence of left heart failure, right? But apart from that, from the right heart catheterization, we do get some information, right? What are we interested in knowing? We are interested in knowing two parameters: pulmonary vascular resistance and pulmonary artery wedge pressure, to classify into pre-capillary and post-capillary, right? Okay, so pre-capillary is characterized by pulmonary artery wedge pressure. See, mean pulmonary artery pressure in both cases is going to be 20 plus. Now, pulmonary artery wedge pressure in case of pre-capillary should be less than 15 millimeters of mercury, and in case of post-capillary more than 15 millimeters of mercury. Clear? So that's the defining point between pre and post-capillary, right? And when you look at pulmonary vascular resistance, now pulmonary vascular resistance means basically we're talking about pulmonary artery resistance. So that would be increased when there is a pre-capillary defect, right? So pulmonary vascular resistance here would be more than 3 Wood units. Now what's the normal pulmonary vascular resistance? Normal is less than 1 Wood unit, or roughly 1 Wood unit. So when it is more than 3 Wood unit, you can clearly say that there is increased pulmonary vascular resistance. Now these are the two important findings that you would see in the pre-capillary defect. Let me give you examples for the pre-capillary defect. Number 1, idiopathic pulmonary arterial hypertension, right? Number 2, lung diseases like your COPD, interstitial lung disease, all of that would fall under this pre-capillary category. Okay. Post-capillary, when you look at the pulmonary vascular resistance, it can be either increased or normal. Pulmonary vascular resistance can be less than 3 Wood units, or it can be more than 3 Wood units. So when it is less than 3 Wood unit, that means the artery side is not affected per se, right? I mean, the arterial primary pathology is not there. There is no increased vascular resistance. It is just the back pressure from the pulmonary vein side, which is responsible for this patient developing pulmonary arterial hypertension, pulmonary hypertension. So in such case, this is called as isolated post-capillary pulmonary hypertension. Isolated, because there is no pre-capillary component involved. It's purely post-capillary, right? An example you need to remember for this is occlusion of the pulmonary veins, an idiopathic condition which is called as pulmonary veno-occlusive disease. Pulmonary veno-occlusive disease. That's an example for an isolated pre-capillary defect. But when you have the pulmonary vascular resistance, which is more than 3 Wood units, that means there is, in addition to a pre-capillary defect, there is in addition to post-capillary defect, there is also a pre-capillary defect. So what do we call this as? This is pre plus post-capillary pulmonary hypertension. And the classical example for this is a left heart diseases. Left heart diseases. Clear? So this is the broader classification, and you should definitely be aware about pre-capillary versus post-capillary. We have learned about 3 numbers. One is mean pulmonary artery pressure. That's used for defining the pulmonary hypertension, more than 20 millimeters of mercury. Then we look at pulmonary artery wedge pressure. If the pulmonary artery wedge pressure is less than 15, it is pre-capillary defect. If it is more than 15, it is post-capillary defect. Problem can be in the pulmonary veins, left side of the other part of the left side of the heart. We will look at the pulmonary vascular resistance, less than 3 Wood units. Then probably the case is pulmonary veno-occlusive disease, which is a rare disease. and it is extremely rare, so you're unlikely to encounter such patients. On the other hand, the pulmonary vascular resistance more than 3 Wood units means that it's a pre plus post capillary defect, most likely a left heart pathology like mitral stenosis or left atrial enlargement because of whatever causes, including left ventricular hypertrophy. All of that would fall under this category, the pre and post mixed, right? Okay, so this is a traditional classification, but the 2019 World Symposium classification has categorized the pulmonary hypertension into 5 groups, right? So group number 1, the group number 1 is pulmonary arterial hypertension, which we have already learned, right? Pulmonary arterial hypertension. In the pulmonary arterial hypertension, as we have already learned, the mean pulmonary artery pressure is going to be more than 20 millimeters of mercury. And because it is the pulmonary arterial hypertension that we're talking about, that means it is a precapillary. So pulmonary vascular resistance will be more than 3 Wood units, and it is isolated precapillary. There's no postcapillary involvement. So when you look at the pulmonary artery wedge pressure, it is going to be less than 15 millimeters of mercury. That's the definition, or that's a parameter that suggests that it's a pulmonary arterial hypertension. Now under this, what are the causes we will see? Idiopathic pulmonary arterial hypertension. Idiopathic, right? You don't end up finding any cause. It can be heritable, and let me tell you one important point. Whenever you talk about heritable pulmonary arterial hypertension, the most common mutation responsible, this is a very important MCQ point, and that is bone morphogenic protein receptor type 2, right? Mutations in bone morphogenic protein receptor type 2, which plays a role in the pulmonary vasculogenesis, is associated with inherited or familial pulmonary arterial hypertension. We're talking about familial pulmonary arterial hypertension, and it is seen in around 75 to 80% of familial pulmonary arterial hypertension. Clear? Okay. Other than that, certain drugs and toxins can also cause pulmonary arterial hypertension. And an example I want you to remember for the drugs is fenfluramine, right? Fenfluramine. Okay. There are other drugs which are associated with pulmonary hypertension. I'll share a list at the end of this video, but fenfluramine is one drug I want you to remember because that has been asked multiple times in NEET PG, so obviously it's going to be important for you also. Okay, then you have this category called pulmonary arterial hypertension associated with other diseases like connective tissue disorders, often like where there is vasculitis or vasculopathy involved. For example, I can think of is scleroderma, which is strongly associated with pulmonary arterial hypertension, right? Scleroderma, sarcoidosis, those connective tissue disorder associated pulmonary arterial hypertension will be under the group 1. Broad heading is pulmonary arterial hypertension. HIV, you should remember that HIV can cause anything in the body, right? Almost you name a manifestation and HIV may be associated with a higher risk of developing that manifestation. So is the pulmonary arterial hypertension. There's a strong association, and that would come under group 1. Okay. Portal hypertension can influence the right heart dynamics, and that can cause pulmonary arterial hypertension. Okay. Certain congenital heart diseases where the flow across the flow into the right ventricle is increased, and thus the flow across the pulmonary valve is increased, and the flow through the pulmonary artery is increased, can also be associated with pulmonary hypertension. And schistosomiasis, right? So this one infection also you need to remember. These are all under group 1. Okay, then pulmonary arterial hypertension can also be defined as long-term responders to calcium channel blockers, which is one of the groups like pulmonary arterial hypertension. You start them on calcium channel blockers and they're responding for several years positively. Good response, functional class, WHO functional class showing improvement. That is one category. Then pulmonary arterial hypertension with overt features of venous or capillaries, and persistent pulmonary hypertension of the newborn syndrome. Okay, we really don't need to bother about these 1.5 to 1.7 categories, but these are the ones which are very important for the NEET SS examination. Now we have a second group. Okay, second group is pulmonary hypertension due to left heart disease. Now in that case, when you do right heart catheterization, what are the findings you are expecting? Obviously, the mean pulmonary artery pressure is going to be more than 20, and your pulmonary artery wedge pressure, because this is a left heart disease, means we are mostly talking about pre plus post. So pulmonary artery post is going to be more than 15 millimeters of mercury, and pulmonary vascular resistance, mostly because it is pre and post, it's going to be more than 3 Wood units, right? I hope that is clear. Now under this, what are the categories you would see? Pulmonary hypertension due to left heart disease, that means anything related to left heart failure. Pulmonary hypertension due to heart failure with reduced left ventricular ejection fraction. Valvular heart disease, right? Your mitral stenosis, aortic stenosis. Congenital or acquired cardiovascular conditions leading to post-capillary pulmonary hypertension. Right? All of that will come under pulmonary hypertension due to left heart disease. That's group 2. Okay, and in group 3, we have pulmonary hypertension due to lung diseases and or hypoxia. Okay, now if you look at the right heart catheterization data of these patients, right, where did we consider the lung diseases? In pre-capillary or post-capillary? Obviously, we considered it in pre-capillary, right? So what are the findings we're going to see? MPAP 20 plus, right? Then pulmonary artery wedge pressure, the deciding point between pre-capillary and post-capillary, is going to be less than 15. Pulmonary vascular resistance will be more than 3 Wood units. That's what defines our group 3 patients, right? So it's very similar to pulmonary arterial hypertension or the group 1 patients. Only difference is that in group 1 patients, we will have the evidence, will not have any evidence of the lung disease. In case of the group 3 patients, in addition to finding the cath lab data that we got in the group 1, we will have evidence of lung disease or persistent hypoxia in these patients. So what are the patients or what are the diseases that come under this heading? You can have obstructive lung disease, restrictive lung disease. Now other diseases which have mixed restrictive obstructive pattern, and there can be chronic hypoxia without lung disease, right? Patients staying in high altitudes and certain developmental lung disorders. All of that would come under group 3 according to World Symposium on Pulmonary Hypertension 2019 classification. Then we have a group 4, pulmonary hypertension due to pulmonary artery obstruction. Now here, the pulmonary hypertension is not because the pulmonary vascular other pathologies were there, like smooth muscle hypertrophy, increased vascular resistance, or it is not because the left side of the heart disease. There is an obstruction to the pulmonary artery. What could be the cause? Chronic thromboembolic pulmonary hypertension, right? Often referred to as chronic thromboembolic pulmonary hypertension, CTEPH, right? In itself is a small topic which we will deal separately in detail. Chronic thromboembolic pulmonary hypertension, and there are certain other pulmonary artery obstruction conditions. All of that would be categorized under group 4, right? Now these group 4's right heart catheterization findings are going to be exactly similar to the group 1 and group 3. Right? You will have the same findings as MPAP 20 plus, pulmonary artery wedge pressure less than 15, and pulmonary vascular resistance more than 3 Wood units. Now, what helps you to distinguish this from group 1 and group 3? Obviously, a CT evaluation of the chest which shows that there is a shower of emboli at multiple locations in the lung, chronic thromboembolic pulmonary hypertension. So, high resolution CT, MDCT plays important role in evaluation and diagnosis of pulmonary hypertension, especially when it typically fits into a pre-capillary defect, because in that case, the problem can be in the pulmonary artery or in the lungs. Okay. The last group is pulmonary hypertension with unclear or multifactorial mechanisms. Like you might have pulmonary hypertension when there are hematological disorders, very systemic or metabolic disorders, or congenital heart disease, which are too complex to simplify into pre-capillary, post-capillary. All of that is grouped under group 5. Like simplest way to remember is group 1, it is pulmonary arterial hypertension starting in the pulmonary artery itself. Now group 2 is on the other side, left-sided heart disease. Group 3 is at the level of lungs or systemic hypoxia. Group 4 is pulmonary artery obstruction, mainly remember chronic thromboembolic pulmonary hypertension, and everything else miscellaneous is group 5, right? Now this classification is important because they might ask, they might name a particular disease or particular cause for pulmonary hypertension, then ask which group it belongs to, whether it belongs to group 1, 2, 3, 4 or 5. Clear? Okay, I think now you have a fair bit of idea about the pulmonary hypertension, its definition, classification, and the terminologies like pulmonary hypertension versus pulmonary arterial hypertension, pre-capillary versus post-capillary, and within post-capillary, you also know what is isolated pre-capillary and your mixed pre-post, right? Now, with this understanding, we will go back to the question that we had already discussed and see if we can answer it. Okay, so after having understood the terminologies and the classification of pulmonary hypertension, it's time for us to go back to the question that we had initially taken up. Let us answer that and then move forward with further discussion. Okay, so here is a question. In the question, we had a 35-year-old female who was evaluated for exertional dyspnea and syncope. Her echo had revealed that there is right ventricular hypertrophy and elevated pulmonary artery systolic pressure. Right heart catheterization data is given below. Right now, I need only the right heart cath data for zeroing down onto the diagnosis, right? So here the mean pulmonary artery pressure is 34 millimeters of mercury. That means this patient has pulmonary hypertension, right? So I do agree with the first diagnosis is that there is pulmonary hypertension. Very clear. Now it's my job to see whether it is pre-capillary, post-capillary. For that, I need the pulmonary artery wedge pressure. Pulmonary artery wedge pressure is 19, right? So we were using 15 as the deciding factor. So 15 plus 19, that means it is a post-capillary, right? There is a post-capillary component. So I'm strongly thinking of left heart diseases or pulmonary veno-occlusive disease. And when we look at the pulmonary vascular resistance, it is more than 3. So that means there is a pre-capillary component also included. So there is a pre-capillary plus post-capillary, right? So that means we are dealing with mostly the left heart disease, right? We are dealing with mostly the left heart disease. Now, among the options, pulmonary arterial hypertension is something that I can rule out, because if it is group 1, pulmonary arterial hypertension, or group 3 or 4, then that would have had the pulmonary artery wedge pressure less than 15 millimeters of mercury. Because it is 15 plus, it is ruled out comfortably, right? Aortic stenosis could have been a reason for pulmonary hypertension, but from the given data, I would consider pulmonary hypertension over aortic stenosis. And if there was aortic stenosis, echo details would have been mentioned. So I'm not thinking of that. Mitral stenosis remains a possible explanation for pulmonary hypertension, but the lack of echo findings or lack of data in the question, I cannot go with the diagnosis of mitral stenosis. So my diagnosis here is pulmonary hypertension due to left heart disease, because it is a pre plus post capillary pulmonary hypertension. Clear? Okay, so now we know how to answer these kind of right heart catheterization data related questions. Okay, now taking forward the further discussion, let us talk about pathophysiology. It is very, very important for us to understand pathophysiology, because we can correlate with the management decisions. Okay, now pathophysiology wise, ultimately what is happening is pressure inside the pulmonary artery, the mean pulmonary artery pressure is going up, right? Now the causes in terms of mechanical causes can be discussed under 3 headings. They can be passively, the pulmonary artery pressure may be going up, or pulmonary artery pressure may be going up because of the hyperkinetic heart, or there can be resistive physiology, which is offering resistance to the flow of blood through the pulmonary artery, right? An example for a passive rise in the pulmonary artery pressure is your left-sided heart diseases, right? So when you have a left-sided heart disease, like let me give you an example of mitral stenosis. So you have a very stenosed mitral valve. So there is difficulty of passage of blood from left atrium to the left ventricle. So the left atrial pressure starts increasing, right? This increased left atrial pressure will reflect onto difficulty of passage of the blood from the pulmonary vein to the left atrium. So pulmonary venous hypertension ensues. Once there is a pulmonary venous hypertension, the flow of blood, which started with the right ventricle to the pulmonary artery, through the capillaries to the pulmonary veins, because the pressure in the pulmonary veins is increased, right? This flow of blood gets hindered, and thus the back pressure on the capillaries, and thus the pulmonary artery increases. So the pulmonary arterial pressure also increases, right? But here the rise in the pulmonary artery pressure is not primarily because of the problem in the pulmonary artery, but rather it is passively going up because the pulmonary venous pressure is increased, right? Now, this is a very simplification of the pathophysiology, because in a left heart disease, right, the neurohormonal modifications that happen or remodeling that happens will affect the pulmonary vasculature also to some extent. That is why whenever we say left heart disease, we are talking about pre plus post capillary. But when you have an isolated post capillary like pulmonary veno-occlusive disease, that typically fits into this description, passive. But even when you say there is left heart disease, passive is the predominant reason why there is pulmonary hypertension, right? Okay, then the second pathophysiology can be hyperkinetic heart disease. Basically, when there is increased volume of flow to the right ventricle, right? It could be because of a VST, right? It could be because of the VST, or it could be because of the pulmonic regurgitation, or the, right? So in such cases, the right ventricular volume increases, so the flow across the pulmonary artery increases, and thus the pressure in the pulmonary artery increases. So that can be called as hyperkinetic, right? Okay. Now the resistive physiology can be either because of the pulmonary vascular pathology in the form of vasculitis and all, like scleroderma, or it can also be because of the resistance offered for the flow of blood through the capillary meshwork in the lungs because of the parenchymal diseases or the pulmonary vascular diseases. So that is the resistive physiology, right? So this is broadly the macroscopic, or in other words, the structural mechanisms behind rise in pressure in the pulmonary artery. Okay, but when you talk about the idiopathic pulmonary arterial hypertension, or herited pulmonary artery hypertension, or familial pulmonary artery hypertension, right? There is more important role than just the mechanics. There is more important role of hormones, or I would say neurohormonal regulation and important messenger pathways, right? So what are the pathways that are involved in the pathogenesis of pulmonary arterial hypertension, especially idiopathic pulmonary arterial hypertension? We're talking about three pathways here. Pathway number one is the endothelin, second one is based on the nitric oxide, and third one is based on prostacyclin. So let us take the pathway number one, endothelin, right? Endothelin is a potent vasoconstrictor, right? Endothelin is produced by the pulmonary vasculature endothelium, and it's a potent vasoconstrictor. Now, endothelin 1 is what is particularly interesting for us, right? And among the endothelin 1, we are particularly more concerned about the endothelin. Endothelin 1 has two types of receptors, endothelin 1 receptor A and endothelin 1 receptor B, right? A plays a more important role. So please remember this point. It's going to be an important MCQ. A plays a more important role. Okay. Now both of these, A and B, what they do is they're secreted by the endothelium, but they act on the vascular smooth muscle. What they do, they cause constriction. They stimulate and thus constrict the pulmonary vasculature. When they constrict, obviously the pulmonary vascular resistance increases, pulmonary arterial hypertension ensues. The second thing they do is they also stimulate the proliferation of vascular smooth muscles, right? It is like sending the vascular smooth muscles to the gym. So they are trained now, more hypertrophied, and their response to the subsequent release of endothelin is going to be much more stronger. So the vascular resistance keeps going up and up as they keep proliferating. So endothelin is going to be a harmful thing for a patient with pulmonary arterial hypertension. So if you have to treat, blocking the endothelin is one of the way we can do, right? So you have heard of the drugs like bosentan. You have heard of the drugs like ambrisentan, right? These are classical examples that block the endothelin receptors. Now, please remember one important pharmacology MCQ. They can ask you which of these endothelin receptor blockers is selective blocker. Now, here selective primarily means we're talking about the ET1 receptor A, right? Okay, most other drugs which belong to this class are non-selective. So that means they act or they block both endothelin receptor 1A as well as 1B. So which one is selective? I've given you two examples which are readily available in the market today, right? Macitentan availability is still a concern in India. Ambrisentan and bosentan are readily available. So which one would you consider as selective? Okay, let me give you a simple hint. A for A, right? Ambrisentan is a selective for A, and bosentan is non-selective. Clear? Ambrisentan is selective. Bosentan is non-selective. Easy to remember. Selective, whenever we talk about, we're talking about selectively acting on the endothelin receptor A, and the drug that acts on it starts with letter A, ambrisentan. Okay. So blocking endothelin is one way we can treat pulmonary arterial hypertension. Okay. Second pathway that is involved is the nitric oxide pathway. Now, body generally will utilize the L-arginine, convert it into L-citrulline, and leads to generation of nitric oxide. Now, nitric oxide is a vasodilator, right? It will stimulate increased production of cyclic GMP. We know very much about it. So it will produce increased cyclic GMP, which causes vasodilatation, and it is also exerting anti-proliferative activity, right? So it is exactly opposite of endothelin. Endothelin is a harmful axis. On the other hand, nitric oxide is a beneficial axis. It causes vasodilatation and it reduces the proliferation of smooth muscles. Now the pitfall here is the cyclic GMP that is produced by the nitric oxide pathway gets hydrolyzed, quickly degenerated by phosphodiesterase 5. So phosphodiesterase 5 has a negative influence on the cyclic GMP, right? It hydrolyzes or converts cyclic GMP to inactive thing by the phosphodiesterase E, right? Which is a bad thing. So if you want to treat a patient with pulmonary arterial hypertension, you can block the phosphodiesterase 5. By blocking the phosphodiesterase 5, you will increase the cyclic GMP levels in the vascular smooth muscles and thus facilitates vasodilation, antiproliferation, and reduce the pulmonary artery pressure. Right? Okay. Now the third pathway includes prostacyclin. Now we all know prostacyclin, the starting raw material is arachidonic acid. From that, we are producing prostaglandin I2. Now, prostaglandin I2 also causes exactly similar things that nitric oxide pathway did, causes vasodilatation and antiproliferation. But here the second messenger system includes cyclic AMP instead of cyclic GMP. Now, this is also a beneficial axis, right? So you can also use, like you can block phosphodiesterase 5, you can block endothelin receptors, and here you can use prostaglandin I2 analogs, or in simple words, prostacyclins for treatment of pulmonary hypertension. Right, so you can use the analogs of these to treat pulmonary hypertension. Clear? Okay, so these are the key pathways involved. Now all these pathways and stuff that we have spoken about applies to pulmonary arterial hypertension. Right, most other causes for pulmonary hypertension are mechanical, like left heart disease, it is mechanical. Lung disease, it is kind of mechanical. So for those cases, these drugs are not well studied and probably are not going to be of much help. If you have a left heart disease, treat the underlying cause. If there's a mitral stenosis, treat it. If you have a lung disease, treat it. But when you have a pure precapillary pulmonary arterial hypertension, these drugs are going to help. Like in other words, idiopathic pulmonary arterial hypertension, these class of drugs can be helpful. Okay. So that's about the key pathways involved. The last point, mainly for the sake of MCQs, they can ask you what is the role of genetics. Several mutations have been identified, but only one mutation I want you to remember, that is bone morphogenic protein receptor type 2 mutations, which are seen in 75 to 80% of familial pulmonary arterial hypertension or heritable, which is again a subcategory under idiopathic, right? Familial, idiopathic, we have seen that 70 to 80% of these patients have that mutation. So if there is a question asking you what is the most common mutation in idiopathic pulmonary arterial hypertension, obviously your answer has to be bone morphogenic protein receptor type 2, right? Okay, so that's about the genetics. Now coming to the clinical features, how these patients are going to present to us. Symptom wise, right, most common symptom is dyspnea, which is initially obviously going to be exertional. Right, exertional dyspnea is the most common symptom. Okay, apart from that, these patients can also present with chest pain, which can also be exertional, so that might confuse you with the other cardiac causes for the chest pain. The third thing is these patients can often present with presyncope or syncope. Presyncope or syncope, right? Some patients might present with poor exercise tolerance. Okay, so these are the presenting symptoms, nothing specific, right? All vague. So you have a plethora of differential diagnosis to evaluate for, right? All these symptoms can be because of anemia, this can be because of a valvular heart disease, this can be because of an ischemic heart disease, and can also be because of pulmonary hypertension. So keep in mind when you have a patient with exertional dyspnea or chest pain or repeated episodes of syncope or presyncope or worsening effort tolerance, in all these cases, keep in mind pulmonary hypertension also as one of the differential diagnoses apart from other important differentials. Okay, when you examine these patients, what are the findings you are going to get? A patient with pulmonary hypertension, when examined, what are the findings we can anticipate? Okay, now number one, I'm talking about more specific findings related to pulmonary hypertension. You can see on auscultation, you can hear a loud P2. Right, you can hear a loud P2. Second, on palpation, you might have a palpable P2, right? You might have a palpable P2. Then the third thing is these patients, because there is a resistance, right? Like I'm talking about, this is pulmonary artery. This is pulmonic valve. This is your right ventricle. This is your right atrium, tricuspid valve, right? Pulmonary artery. Now, as the pressure in the pulmonary artery starts going up, right ventricle has to do more and more work. So over time, right ventricular hypertrophy develops, and that findings may be evident on clinical examination, right? What could that be? You can have a right ventricular heave, right? Then fourth, you can have the evidence of right ventricular S4, right? Apart from that, more advanced cases, the right ventricle might fail. So you might have features of right ventricular failure. So that includes raised JVP, right? You can have tender hepatomegaly. You can have pedal edema, all the findings of the right ventricular failure. These are the findings you can anticipate, right? Apart from that, if there is an underlying cause, right? If there is a pulmonic valve lesion, right? Those findings would be there, right? Patients might develop the pulmonic valve regurgitation, so those findings may be there. So like any other structural changes that happen to heart, you might get those findings. Okay, so please at least remember that you might have a loud P2, you might have a palpable P2, you might have right ventricular heave, you might have right ventricular S4. On the right ventricular failure, once it sets in, you might have the right ventricular S3 also heard, right? And you might have features of right ventricular failure. Apart from that, the underlying cause, like if there is a COPD patient, then the evidence of hypoxia, emphysematous chest, all those findings would be there, right? Okay, so that's about physical examination. Now coming to the evaluation of the case. Now, most of these patients, right, when they present with this cluster of symptoms of dyspnea on exertion, chest pain, effort tolerance issues, and pre-syncope or syncope, one of the starting point would be to do a ECG, chest X-ray, and an echo, right? In the ECG, the evidence of the right ventricular enlargement in the chest X-ray as well as ECG, there may be evidence of right ventricular enlargement, right? But they are not very specific findings. So most importantly, we'll start with echo, right? Echo is our initial best starting point. So when you do echo, in the echo, you might notice the right ventricular hypertrophy, and you will get the pulmonary artery systolic pressure, right? If you remember, I told you pulmonary artery systolic pressure and right ventricular systolic pressure are same if there is no pathology in the pulmonic valve, right? Now, this pulmonary artery systolic pressure is not enough for us to diagnose a case of pulmonary arterial hypertension or pulmonary hypertension per se, right? What do we need? We need the MPAP. So how do we calculate MPAP? Best way is, yes, right heart catheterization itself, but there's a formula that can help you to get a rough number for mean pulmonary artery pressure. The formula is 0.61 into pulmonary artery systolic pressure plus 2 millimeters of mercury. So let me give you an example. If the pulmonary artery systolic pressure is 50, right, multiply 50 with 0.61, whatever that number it is, add 2 to it, and you get your mean pulmonary artery pressure, right? My mathematics is weak, I'm not going to waste your time, but this is how you calculate the mean pulmonary artery pressure. Okay, is that a reliable number? Not as reliable as directly doing a right heart catheterization. So what is the gold standard for diagnosis of pulmonary hypertension? It is right heart catheterization and getting an accurate measurement of MPAP. But you can guess or get a rough number for the MPAP from the echo if you have the pulmonary artery systolic pressure. Echo will give you a lot more idea about right ventricular dimensions, right and left ventricular pathologies, right-sided, left-sided heart failure, valvular lesions, everything. So it might, in addition to giving you a clue that this patient has pulmonary hypertension, it will also probably open up your eyes for the underlying cause if it is related to heart. So echo is one of the good starting point investigation. Okay, but as I've already told you, right heart catheterization is the gold standard. And just to reiterate, I'm just repeating the same information. So we start with the mean pulmonary artery pressure. Mean pulmonary artery pressure more than 20 millimeters of mercury. You have classified the case as pulmonary hypertension. After that, we will look at pulmonary artery wedge pressure, right? If that is less than 15 or more than 15, if it is more than 15, it has a post-capillary component. You can call it as post-capillary pulmonary hypertension, and less than 15, it is a pre-capillary pulmonary hypertension. So under this pre-capillary pulmonary hypertension, pulmonary vascular resistance would be increased, so more than 3 Wood units. As I've already told you, normal is 1 or little less than 1. And in this, according to the latest classification, group 1, right, and then group 3 and group 4, right? So group 1 is which one? Pulmonary arterial hypertension. Group 3 is lung diseases, and group 4 is chronic thromboembolic pulmonary hypertension, right? That's your pre-capillary, right? Post-capillary, your pulmonary artery wedge pressure is more than 15. Then we will see pulmonary vascular resistance, right? If it is more than 3, then there is a pre-capillary plus post-capillary pulmonary hypertension, and you would strongly think of left heart disease in that case, right? And when it is less than 3, there is no pre-capillary component, less than 3 Wood units, then you would think of isolated post-capillary pulmonary hypertension. You would think of pulmonary veno-occlusive disease as one of the examples. Okay, so I hope this right heart catheterization data is not going to confuse you to solve any pulmonary hypertension related questions. I think it's substantially clear. Only 3 values: MPAP, pulmonary artery wedge pressure, and pulmonary vascular resistance, right? Okay. No, so that's going to be our gold standard, and you should know. After you diagnose the case of pulmonary hypertension, what are the next steps? How do you evaluate further, and how do you manage? Diagnosis, as you already know, right? We are mostly relying on the right heart catheterization. Yeah, once you get to know that it belongs to what category or what group, further evaluation is definitely required. Like, for example, if it belongs to group 1, right, or if it belongs to group 3, definitely I need to evaluate for the lung diseases, right? So all the pre-capillary, I might have to do a CT of the thorax, so that I can confidently say it is pulmonary arterial hypertension group 1 and not group 3 once the CT is normal. Or if there is an ILD or something suggestive of a lung disease, then I can put it in group 3, right? Similarly, CT, particularly CT pulmonary angio, would help you to pick up the chronic thromboembolic pulmonary hypertension, right? So there is CT chest is a very important imaging modality in a pre-capillary case, right? Post-capillary, because pulmonary veno-occlusive disease is very rare for all practical purposes, most cases are going to be left heart disease. So an echo or more detailed left heart catheterization will give you much more understanding about what is wrong with the heart, and you can manage accordingly, right? So you have made a diagnosis, you have a clear-cut diagnosis between diagnosis of pulmonary hypertension is established and a cause is also established. Then comes the question of management, right? So for management, especially the pulmonary arterial hypertension, right, it is very, very important for us to know the functional status of the patient. Because what we use, whether we use a monotherapy or a combination therapy, it all depends on the functional status of the patient. Now, how do we assess functional status? There are various ways, but most commonly we will follow either the WHO functional class or 6-minute walk distance. Now remember, 6-minute walk distance is particularly more useful not for making the decision with respect to what to start with. It is mainly used for assessing the progress during your outpatient follow-ups. You have a case of pulmonary hypertension, you started them on particular medications, and once he comes for follow-up, to see whether his functional status is improved or not, we will calculate a 6-minute walk distance, like on initiation of treatment, during subsequent follow-ups. So if this 6-minute walk distance is improving, that means he is responding well to medication. It's a simple OPD office procedure that you can do, right? But most importantly, to initiate the treatment, it is the WHO functional class. So there are 4 functional classes of patients with pulmonary hypertension. So class 1 is a patient who is diagnosed with pulmonary hypertension, but he doesn't have any limitation to his physical activity, right? So it's like routine echo screening, or because you were evaluating for some other symptoms and you got him evaluated for pulmonary hypertension, you have diagnosed him as having pulmonary hypertension, but this pulmonary hypertension is not affecting his physical activity, right? So for this patient, ordinary physical activity does not cause any dyspnea, fatigue, chest pain, or presyncope, right? That is functional status class 1. So what is class 1? Class 1 means there is pulmonary hypertension present. Class 0 is where pulmonary hypertension is not there, right? But no limitation of physical activity. physical activity. That is your class 1. Okay. Then you have a class 2 patient. Class 2 patients also have pulmonary hypertension, but this patient experiences slight limitation of physical activity. At rest, they are absolutely comfortable. Ordinary physical activity causes some undue dyspnea or fatigue, chest pain, or near syncope. Right? That is class 2. So class 2 is pulmonary hypertension case with slight limitation to physical activity. Slight limitation, not profound, right? Then you have class 3 where patients have pulmonary hypertension resulting in marked limitation of physical activity, right? So here, less than ordinary activity. Remember this point now. Class 3, pulmonary hypertension present. The word used is marked limitation of physical activity. Basically, less than ordinary activity itself triggers dyspnea. But at rest, they're still comfortable. That is class 3. Class 4 is when patients have pulmonary hypertension and they have inability to carry out any physical activity. In other words, class 4, they have pulmonary hypertension and dyspnea at rest symptoms, or dyspnea at rest. That's your class 4. Okay, so whenever you have a clinical question where history is suggestive of pulmonary hypertension or right heart cath data is suggestive of pulmonary hypertension, also look into the question for what class he belongs to, because what drug you choose to treat him depends on what class he belongs to, whether he belongs to class 1 to 3 or class 4, right? That's going to be a deciding factor. Okay, so please remember, class 1 pulmonary hypertension but no limitation of physical activity. Class 2 slight limitation of physical activity. Ordinary activity triggers some degree of dyspnea or syncope or pre-syncope. The class 3 is where less than ordinary or marked limitation of physical activity or less than ordinary activity itself triggers dyspnea, but at rest somehow they're comfortable. Class 4 is where they have symptoms at rest. They are unable to carry out any level of physical activity. Clear? Okay. 6-minute walk distance, as I've already told you, it's more of a simple tool to assess the improvement in functional status or worsening of functional status in outpatient practice, right? Doesn't hold any role in the guidelines. Okay. Now coming to the management. Okay. So management depends on the group of the patient, right? If it is group 1, right? Group 2, group 3, group 4 and group 5, right? So just to reiterate, group 1 is pulmonary arterial hypertension, group 2 is pulmonary hypertension due to left heart disease, group 3 is due to lung disease or hypoxia, group 4 is chronic thromboembolic pulmonary hypertension, group 5 is miscellaneous, right? Now left heart disease, group 2, treat underlying cause, whatever it is, treatable, treat it. Patient's pulmonary artery dynamics would improve to some extent. You might expect a symptomatic improvement. Group 3, again, underlying lung disease to be treated. Treat underlying disease. Okay. Chronic thromboembolic pulmonary hypertension, you would think of anticoagulation, right? That's going to be your treatment. And miscellaneous, again, if possible, treat underlying cause. So in simple words, whatever pharmacotherapy that we are going to discuss subsequently is for a patient with group 1 or pulmonary arterial hypertension, right? There also, if it is mainly about an idiopathic or inherited or familial, rather than if there's a specific cause, you will treat the cause. Like HIV, treating the HIV viral suppression would improve the pulmonary dynamics and would help in symptomatic improvement of the patients. So underlying cause, if treatable, you will treat in group 1. In all other idiopathic cases, you will think of medications. We have learned about 3 pathways. So focus on medications will be on those 3 pathways, right? What are the pathways we have learned about? We have learned about endothelin, we have learned about nitric oxide, and we have learned about prostacyclins, right? Prostacyclins. So you can think of either blocking the endothelin, or to facilitate nitric oxide action, you can block the phosphodiesterase 5. And for prostacyclins, you can use the prostaglandin analogs. So PGI2 is supposed to be favored. So you can use prostacyclin analogs like epoprostenol, treprostinil analogs. So these are the options that are available for treating the group 1 patients. But there are some other class of drugs which can also have vasodilatory benefit, and they may also be helpful in this patient, right? So I'm particularly talking about calcium channel blockers. There's a fourth class of drugs you can think of. Okay, now how do you make a choice between these? Whether you want to go with calcium channel blockers or endothelin receptor blockers or the phosphodiesterase 5 blockers or the prostacyclin analog. That is what depends on two things, right? So the first thing you need to know is the WHO functional class, and the second thing you need to know is what is called as vasodilatory testing. Vasodilatory testing. Now this vasodilatory testing basically decides the or predicts the response to CCBs. So we are doing the vasoreactivity testing or vasodilatory testing to predict the response to calcium channel blockers. Now, why are we testing the response to calcium channel blockers? Because in many patients of pulmonary arterial hypertension, there is a reversible component to the pulmonary resistance. So pulmonary resistance is partly because of the increased vascular tone, and it's partly because of the irreversible remodeling. Now, by giving calcium channel blockers, we will be helping that partially reversible increased tone. And to predict whether the patient is going to respond to calcium channel blockers or not, we do the vasodilatory testing. Now, how do we carry out this test? We carry out this test by giving patient diagnosed with pulmonary hypertension, we give them nitric oxide or inhaled form or IV epoprostenol. Now, these are the agents which are used for knowing the vasoreactivity, right? After administering this, what are we expecting? We are expecting, if there is a good response, right, we are expecting their mean pulmonary arterial pressure to decrease by more than or equal to 10 millimeters of mercury. Now, let me complicate it a bit. It's not just merely 10 millimeters of mercury, right? Please again pay attention to my statement. The mean pulmonary artery pressure should decrease by more than or equal to 10 millimeters of mercury to an absolute value. Of less than 40 millimeters of mercury. Now, what do I mean by this? Okay, let me give you an example. So here is a patient number 1 whose mean pulmonary artery pressure is, let me say, 60 millimeters of mercury, right? After administration of nitric oxide inhaled, right? Obviously, you're doing all this in the cath lab only. His mean pulmonary artery pressure has now dropped down to 52 millimeters of mercury, right? That's our patient number 1. And we have a patient number 2 whose mean pulmonary artery pressure is 48 millimeters of mercury. And after the nitric oxide, it has dropped down to, let me say, 38 millimeters of mercury, right? Now, the patient number 1 will be said to have a failed vasoreactivity test because his mean pulmonary artery pressure has decreased by 18 millimeters of mercury, even if, okay, let me just change the number and make it 48. So it has definitely decreased by more than 10 millimeters of mercury. So this point is satisfied, but the final value is not less than 40 millimeters of mercury, right? So such patients, even though they're showing some degree of vasoreactivity, in terms of clinical benefit, we are not going to say much once we start giving them calcium channel blocker. So that's why this is a failed vasoreactivity test. Okay. Or in other words, you can say negative vasoreactivity test. But this patient number 2, right? He is the one who is showing or who is satisfying both the criteria. The drop is 10 millimeters of mercury, right? 48 to 38. And the final value is less than 40. So it's a positive vasoreactivity test. Now, this is a patient who is likely to be benefited by calcium channel blockers. Okay, so I hope you have understood, right? Vasoreactivity testing, we give the patient either inhaled nitric oxide or IV epoprostenol when the patient is in the cath lab and right heart catheterization is being done. We calculate the mean pulmonary artery pressure before and after administration of inhaled nitric oxide or the other agent. And if the mean pulmonary artery pressure decreases by more than or equal to 10 millimeters of mercury to a final value after the decrement to less than 40 millimeters of mercury, you would say vasoreactivity testing is positive, and these patients may be likely benefited by calcium channel blockers because there is a reversible increased vasoconstriction there, right? Again, if it is a class 4 WHO functional status patient, then calcium channel blockers may not be a wise choice. So it is generally recommended for class 1 to class 3 patients, right? Okay, so that is a basic point I want you to know, right? So let me give you an overview of how we manage a case of pulmonary hypertension. Now, all this discussion is, let me again make it clear, related to group 1 patients, particularly idiopathic pulmonary arterial hypertension. The indications for vasoreactivity testing or vasodilatory testing include idiopathic pulmonary arterial hypertension and also drug-induced pulmonary arterial hypertension, like fenfluramine, right? There may be a role of reversibility, so you can do this. Clear? Okay. Now, before I give you the holistic approach to the management of pulmonary hypertension, let us take a look at what are the drugs available at our disposal. We are already familiar with the pathways involved. So, and we have also discussed the vasodilatory testing. So, calcium channel blockers are one of the class of drugs. Like examples or most commonly used drugs are amlodipine, nifedipine, and diltiazem. Right? These are the 3 drugs which are routinely used if the vasoreactivity testing is positive. Right? That's one class of drugs. Then we have endothelin receptor antagonists like ambrisentan, bosentan, and macitentan. Now, the concern with the endothelin receptor antagonists is that they have some degree of hepatotoxicity. In India, most commonly prescribed drug is bosentan which is readily available. Okay, then phosphodiesterase type 5 inhibitors, nitric oxide pathway we are talking about. We have sildenafil and tadalafil. Tadalafil is preferred because of its long acting, right? It is long acting, so it's a OD dosing. Sildenafil is short acting, so you have to give BD TID dosing. So that's why tadalafil is preferred here. And as you already know for Viagra, you know that you should not combine the phosphodiesterase drugs with any nitric oxide donors or guanylate cyclase stimulators like riociguat, which we will be discussing later, right? Okay, then you have a class of drugs called as guanylate cyclase stimulators or GCS, which again act through nitric oxide pathway, and example is riociguat. Same precautions as in case of phosphodiesterase 5 inhibitors. Do not combine it with nitric oxide donors and phosphodiesterase 5 inhibitors. Okay, now one extra point you have to note that this drug has been also approved for the chronic thromboembolic pulmonary hypertension, that is group 4 according to the World Symposium on Pulmonary Hypertension classification, right? Group 4 also. What we are talking is all mainly for group 1, but this drug riociguat is also approved for group 4 patients. Okay, prostacyclin analogs, 4 important drugs to remember. First one is epoprostenol. It is the preferred agent in IV form for functional class 4 patients, whether it is group 1 or any other in group 1, and to be more precise, whether vasoreactivity testing is positive or negative, if it is a functional class 4 patient, it is a preferred agent, prostacyclin analogs. Okay, epoprostenol to be more precise, and it's only available in IV form and it is a continuous infusion. That's the only problem with this class of drugs, right, which are available as IV prostacyclin analogs. They need to be given as continuous infusion and it becomes definitely a cumbersome thing, right? Then you have iloprost, which is inhaled, and you have treprostinil, which is subcutaneous, also available as IV, and subcutaneous is also a continuous infusion. Now, there's one more drug I want you to remember extra, that is from the prostacyclin analogs, that is beroprost. Now, beroprost is a oral prostacyclin analog. So this was an MCQ in one of the recent INISS, so please note this is a oral prostacyclin analog, right? So epoprostenol you are aware of, it is IV, treprostinil IV as well as subcutaneous. Iloprost inhaled, IV is rarely used, so inhaled is what we know. Iloprost inhaled, treprostinil subcutaneous as well as IV. Subcutaneous is a preferred route, continuous infusion. If not tolerated, IV infusions are given. Epoprostenol is only available as IV and it is the preferred agent in functional class 4 patients, right? Beroprost is the right now only orally approved agent. Okay, so that's a class of drugs, prostacyclin analogs. And then we have a last class of drug, that is prostacyclin IP receptor agonists, right? So instead of structural analog of the prostacyclin, we're trying to act through the receptors. And the example for this is selexipag, which is given in the oral form, right? These are the drugs available to us. So we have calcium channel blockers, endothelin receptor antagonists, drugs acting through prostacyclin. It could be analog or a receptor agonist, or you have a guanylate cyclase stimulators or phosphodiesterase 5 inhibitors, both of these last classes dealing with nitric oxide pathway, right? Now let us see how do we make use of these agents. The starting point for any patient of pulmonary hypertension is that we should start considering the functional status and also supportive measures, right? Supportive measures include supervised exercise training. You cannot let them have aggressive physical activity because that can precipitate presyncope, syncope, dyspnea, as well as chest pain. They definitely demand a psychosocial support, right? They should avoid strenuous physical activity. And yeah, another important MCQ point, that is, what are the vaccines recommended for patients according to World Symposium guidelines? Vaccines recommended for patients with idiopathic pulmonary arterial hypertension include influenza and pneumococcal. Influenza and pneumococcal, 2 vaccines to remember. Okay. The other measures include that you might have to consider oral anticoagulation. Oral anticoagulation. In what class of patients it is indicated? It is indicated in idiopathic pulmonary arterial hypertension, heritable or familial pulmonary arterial hypertension, and pulmonary arterial hypertension associated with anorexins like your fenfluramine, right? Now, if you are using warfarin, right, what is the target INR? That can be an MCQ. Target INR is 1.5 to 2.5. 1.5 to 2.5. Now, diuretics might help in symptomatic benefit, especially if there is a right heart failure. So, diuretics can be considered. Oxygen is recommended if SpO2 is less than 90%. So, target SpO2 is more than 90%. Right? It's more than 90%. So if patient is not able to maintain that, you can definitely consider supplemental oxygen. Okay. Digoxin is not strongly recommended. Okay. So that's about the supportive measures. Once the supportive measures are taken care, we are subjecting the patient for acute vasoreactivity testing. Please note that this acute vasoreactivity testing should be done in experienced centers. Right? Okay. So once you have done that, as I've already told you, when you call it as vasoreactive or positive, when the mean pulmonary artery pressure decreases by more than or equal to 10 millimeters of mercury and the final absolute value of mean PAP is less than 40 millimeters of mercury, then you say it is vasoreactive or positive. Okay. If it is positive and patient belongs to the WHO functional class 1, 2, 3, not talking about 4 here, right? 4, even if it is vasoreactive, the management is with more advanced steps, right? If it is functional class 1, 2, 3, you will start with the calcium channel blockers, right? Amlodipine or nifedipine or diltiazem right? Now, once you start these medications, during the subsequent follow-up, you will assess the patient's clinical improvement looking at the functional status itself. So if the functional status is downgraded, like someone with a functional status 3, class 3, right? That patient, if he is having a slight limitation of physical activity, especially to the less than ordinary activity, is having limitation of physical activity, right? Class 2 is where he has slight limitation on ordinary activity. Class 1 is that he doesn't have any limitation in physical activity. 1, no limitation. 2, slight limitation on ordinary activity. 3, limitation on less than ordinary activity. So a patient who had limitation of physical activity, because even the less than ordinary activity he couldn't carry out, with calcium channel blockers, if he's able to carry out ordinary activity, right, now his class is improved to class 2. That's a good response, right? So if there is a sustained response in terms of improvement in the WHO functional class, then you will continue with the calcium channel blockers. As long as he is showing sustained improvement, you will continue. Once you start noticing that the functional class is worsening, 2 is becoming 3 or 3 is becoming 4, then you will switch to more advanced treatment, right? And if no such response, like you did a vasoreactivity test was positive, you started on calcium channel blockers, but you don't see a sustained improvement, functional status remains same or worsens over time, then you will think of the other drugs which are approved for pulmonary arterial hypertension. That is one arm. And if the patient is non-vasoreactive or the vasodilatory test is negative, in those cases, again, you are starting with the pulmonary artery hypertension approved drugs. Now here the choice to make is whether you want to start with a single drug or whether you want to start with a combination therapy. And again, the deciding factor here is the functional class. So if the patient's functional class is 2, WHO functional class 2. Those patients will be treated with monotherapy, single agent. If the functional class is 3 or 4, you will treat with initially itself, you're starting with a combination therapy, right? Clear? So functional class 1 monotherapy, functional class 2 monotherapy, and functional class 3 initial combination therapy, functional class 4 obviously initial combination therapy, right? Now, based on the clinical trials and the evidences, there are different levels of recommendation for the drugs. I want you to remember the recommendations, class 1 recommendations. So for functional class 2, you can use endothelin receptor antagonist like ambrisentan, bosentan, or macitentan, or a guanylate cyclase stimulator like riociguat, or a phosphodiesterase 5 inhibitor like sildenafil or tadalafil. One drug you will start. Depending on response, you will think further. On the other hand, for the WHO functional class 3, you will start with a combination of at least 2 drugs. What is the most commonly used combination? Most commonly used combination is an endothelin receptor antagonist plus a phosphodiesterase 5 inhibitor. That's the most commonly used combination. And most commonly used endothelin receptor antagonist is ambrisentan plus tadalafil. That's the most commonly used starting combination. But you can also consider combining other things, keeping in mind that you cannot use 2 drugs acting through the nitric oxide pathway. That point we need to always remember, right? So in this class, the drugs that are listed include IV epoprostenol, inhaled iloprost, or riociguat, sildenafil, tadalafil, treprostinil subcutaneous, or inhaled. These are the things, right? Forget about the 2A or 2B recommendations. Just for the sake of MCQs, please remember Beraprost is a oral prostacyclin analog, right? What the other prostacyclin analogs that we have discussed are either inhaled, subcutaneous, or IV. Now, if it is a functional class 4, again we are talking about a combination therapy, but one of the agent that you're using in the combination therapy should be IV, right? IV. And what did we learn? Epoprostenol IV is the preferred agent. So that's going to be one of the standard component of your functional class 4 patients. Whether patient is vasoreactive or not, we are going to start with epoprostenol plus another agent, right? Which could be an endothelin receptor antagonist or a phosphodiesterase 5 inhibitor. That's the combination that probably we would start with. Now, as I've already told you, the main limiting factor of executing the treatment of functional class 4 is that this epoprostenol needs to be given as a continuous IV infusion. Okay. Now, what if the initial combination therapy that we started based on the functional class, if it fails? How do we manage further, right? If there is a inadequate clinical response, then you can think of 2 things. Either consider the patient for lung transplantation, or still try to do permutation and combinations, try to manage medically. So if you're thinking of medical management, you can follow something called a sequential combination therapy, where sequentially you will combine with endothelin receptor antagonist, prostanoids, and guanylate cyclase stimulators. That's one approach. Better left to the pulmonologist or cardiologist to further manage these kind of cases, right? Until here it is the physician's territory. And sometimes even the sequential combination therapy, if the response is not good, then again you are pushed towards the lung transplantation, right? And you can also consider balloon atrial septostomy. Balloon atrial septotomy. These are the options that you have in case of difficult scenarios where patient is not responding to initial combination therapy and subsequently to the sequential combination therapy, right? Okay, so that's how we manage a case of pulmonary hypertension. Before signing off, reiterating, if it is a case of group 2, 3, 4, or 5, we basically try to treat the underlying cause, right? Whatever we have discussed in terms of drugs and management, it applies to group 1 patients. To be more precise, or like the data comes mainly from the idiopathic pulmonary arterial hypertension patients. With that, I'm signing off. Please go to the QBank and solve questions related to pulmonary arterial hypertension and make sure that you have learned the essential points. Some of the questions may be based on the previous understanding of the disease, but whatever we have covered today is the one which is relevant for today. So please apply the concepts that we have discussed today for MCQs. Even if the question, your answer turns out to be wrong in the app, communicate with us on the Telegram or Facebook for more clarity. Thank you.